Dr. Neil Jones, let's talk about carpal tunnel syndrome for a moment. What is carpal tunnel syndrome and what causes carpal tunnel syndrome?
Carpal tunnel syndrome describes a compression or a pinching of the main nerve, the median nerve, to the hand, where it passes from the forearm through the wrist into the hand. Usually we don't know for sure what causes carpal tunnel syndrome. It can occur after wrist fractures. It can occur after certain, in association with certain conditions such as diabetes, rheumatoid arthritis, and some hypothyroid conditions. And also you can get it in pregnancy and in the menopause.
How do I know whether I have carpal tunnel syndrome? And what are some usual symptoms of carpal tunnel syndrome?
Patients usually present with symptoms of pain, which is usually over the palm side of the wrist and the forearm and hand. But usually they present with tinglings, pins and needles sensation, and that's usually in the distribution of the median nerve, in the thumb, the index finger, the middle finger, and the thumb side of the ring finger. And in the later stages they have decreased sensation or numbness in the thumb and the index, middle, and ring fingers. In addition, they may sometimes have pain, referred pain up at the level of the shoulder.
Do these type of patients need any tests?
Usually we examine the patient, we tap over the median nerve, and that's called a Tinel sign, which usually gives them a sensation of electric shocks. We press over the nerve, and sometimes that reproduces their symptoms of numbness and tingling. And then obviously we put them in a provocative position, which is called Phelan sign, which is the sign that they get numbness and tingling when the wrist is flexed down. And that explains why these patients get numbness and tingling when they drive or read a newspaper. And then we test the sensation in the thumb, the index finger, the middle finger, and the radial side of the ring finger. And we also test the power of these muscles here at the base of the thumb, the thenar muscles, which are supplied by the median nerve.
So then,
and then we may occasionally get an X-ray to make sure they haven't had a previous fracture, and then occasionally we'll get blood tests such as those for diabetes, a blood glucose, or tests for rheumatoid arthritis or thyroid function tests.
Great. So what is the treatment for carpal tunnel syndrome?
Usually before we do any treatment we try and get what's called a nerve conduction study, which is a way where we can get an idea of the speed of conduction of the median nerve from the forearm into the hand. And this nerve conduction study will tell us, well, first of all, will confirm the diagnosis and then tell us whether it's mild or moderate or severe. And then the treatment starts initially with conservative treatment. We obviously tell the patients not to put their wrists in a flexed position for prolonged periods. We try and prevent them doing repetitive movements of the wrist. We give them a splint to try and immobilize the wrist either in a neutral position or slightly extended, and then we can treat them with anti-inflammatories. Occasionally we will give them an injection of steroid, cortisone, into the the wrist just before the carpal tunnel, and that may sometimes shrink down the swelling and take the pressure off the nerve. If the patients fail to respond to conservative treatment, then usually we talk to them about having surgery, and that usually entails an operation called a carpal tunnel release. That's a relatively simple operation. It's done as an outpatient. It's done under local anesthesia or just blocking the arm. The patients don't need to have a general anesthetic. But essentially the carpal tunnel is in this area here, and there's a very strong ligament passing across the nerve. And the whole concept of a carpal tunnel release is to cut through that ligament and take the pressure off the nerve. It can be done in two ways. The conventional way is to make a small incision here in the palm of the base of the palm of the hand, or it can be done endoscopically with a small incision here in the wrist crease where we place a telescope inside the carpal tunnel and cut the ligament from inside out. But that is usually a very good operation for the great majority of patients, and will get rid of their symptoms of pain, get them back normal sensation again, and get rid of their symptoms of numbness and tingling at night.
Great, thank you. Let's move on to a different subject, another common hand pathology of Dupuytren's contracture. What is Dupuytren's contracture, and what causes Dupuytren's contracture?
Dupuytren's contracture is a very strange condition that affects the hand, in which the fascia, the sort of gristle tissue within the hand, within the palm of the hand, contracts, and the fascia is really a tissue beneath the skin and the subcutaneous tissues, but above the tendons that flex the fingers. It initially starts by the formation of little nodules, firm nodules, in the palm of the hand, and then these gradually form what are called cords, which then contract and pull the fingers down into a flexed position. What causes it is still really unknown. It's certainly associated with patients who have an ancestry in Northern Europe, so it's much more common in Germans, Norwegians, Swedish, the Celts, the Scottish, the Irish and the Welsh are very prone to develop Dupuytren's, but the exact cause is really not known.
What are some of the symptoms of Dupuytren's contracture?
Patients usually consult their physician because either they feel a firm nodule in the palm, which is sometimes painful when it first starts out, but many times patients just develop a progressive contracture of the fingers, usually the ring finger and the small finger, so that the fingers are pulled down into the palm and the patients are unable to extend these fingers. It's very different to a trigger finger, which describes a condition where the patient flexes the finger and then has clicking or catching of the finger when they straighten the finger out. Dupuytren's patients can't straighten the finger out completely, so they can't put their hand flat on the table because of the contracture of the fingers.
So what are some of the treatment options for these type of patients?
There are really three types of treatment options now. The first one, there is now an enzyme called collagenase, which dissolves collagen, which is the building block of these cords, and you can have an injection into the cord, which will then, the enzyme will eat into the cord, and the following day you can manipulate the finger to get it straighter, so that doesn't involve any surgery. The second is that you can, under local anesthetic, take a needle and with the tip of the needle cut through the cord so that again the finger can be stretched out into extension. That's a technique called needle aponeurotomy. And then finally there's the conventional surgery, which usually involves incisions in the palm that then through the incision the surgeon can excise, he can cut out these cords of abnormal tissue and then restore extension to the fingers. Usually it can be done through a zigzag incision, although now we tend to use very small transverse incisions at the level of the joints. This is the PIP joint here, this is the MCP joint here, and then back in the palm. But that surgery is also can be done as an outpatient. It can be done without putting the patient to sleep. It can be done under a block anesthetic, and then usually the patients are splinted for a few days but very rapidly start to bend and straighten their fingers under the supervision of a therapist. Dupuytren's is a strange condition, and there is a propensity for this contracture to recur, and so even if you do the full surgery it can still recur, but there's probably less of a chance of it recurring after the conventional surgery compared with either using the injection or using the needle aponeurotomy. But we don't have good enough studies yet to say which of these is the best for the patient. So patients really need to see a surgeon who is able to do all of these techniques and can give a very good evaluation of which is going to be the best technique for that particular patient.